Hello, everybody, and welcome to the Hughes Clues Renal Dysfunctions. This is part two. And we talked about in part one about acute kidney injury and all of the defining characteristics of that problem. So, how does that differ from chronic kidney disease? Well, the answer to that is time. So, when we talk about the criteria for chronic kidney disease, we say that it is a glomerular filtration rate of less than 60 mils per minute that has occurred for 3 months or longer, and that's with or without kidney disease. So when we think about acute kidney injury, we know that the individuals will have a decline in kidney function because of an acute problem, and that if that acute problem is fixed quickly enough, then the kidneys have the potential to recover. But let's say that the problem can't be fixed, that it becomes more of a permanent problem, and so then if this occurs where the kidney function has been less than 60 mils over 3 months or longer, then now that person is then shifted into or diagnosed with chronic kidney disease. Now, some individuals don't have acute kidney injuries. They just have chronic problems such as diabetes or hypertension. And when those two illnesses, diabetes and hypertension, are poorly managed, then that slowly over time can cause chronic kidney disease. There are other causes of chronic kidney disease. There's polycystic kidney disease, a genetic illness that can cause it. So there's several things that can cause chronic kidney disease. Diabetes and hypertension are the most common. Now, in Dr. Reed's notes, she does list diabetes as the most common cause of chronic kidney disease. Now, once a diagnosis of chronic kidney disease is identified, then the patient is staged. In other words, how poorly is the kidney functioning? In other words, they are staged. The kidney disease is staged by the glomerular filtration rate because that tells the healthcare provider how poorly or how wellish that the kidney is actually working. So this is a physician responsibility, and of course there's a recipe for what stage the patient is in. Now, I said to you that the CKD is staged by the glomerular filtration rate, but we can't directly measure the glomerular filtration rate. So instead, the creatinine clearance is used. Now, you probably remember creatinine clearance, a way to calculate that. There's a formula. You might have seen it in pharm. You don't have to know it. You don't even have to know it exists. You just have to know that for healthcare purposes, we cannot measure the glomerular filtration rate. We can only kind of estimate it, and the best estimated or the closest estimator is the creatinine clearance. So for all intents and purposes, GFR is the same thing as creatinine clearance. So who's at risk, or or how is CKD staged? Well, an individual or patient will be placed at risk if their glomerular filtration rate is 90 or above. So we say that normal glomerular filtration rate is somewhere in the 125, and so if it's 90, then they're at risk, but it's still working good. The kidney's still working good. And then we say that if you're at stage 1 is when there is kidney damage and a glomerular filtration rate of 90 and above. Then we go down to stage 2, 3, and 4. You can see how the glomerular filtration rate is drastically down. Medications are not usually altered. The doses are not usually altered until about the patient's creatinine clearance is less than or equal to 30 or below. Some medications are at 60. You won't need to know this until you're a prescriber, like a nurse practitioner, if you go to medical school. And then any patient who has a glomerular filtration rate of less than 15 mils per minute is then on dialysis. That's stage 5. So you don't have to memorize any of these stages. What the nurse really needs to know is that if a patient was diagnosed with stage 1 or stage 2 kidney disease, then all of a sudden in a very short time period they came back in and they're now at stage 4, well, then you know that something's going on with the patient. They're not keeping their glucose in check, or they're not taking their medications as they should. So it's really, from the nurse's standpoint and knowledge of staging, is about teaching. So what nursing teaching or interventions would you deploy for AKI and CKD? And notice that I say that these are interventions for either, because it doesn't matter whether it's an acute problem or a chronic problem. The bottom line is the kidney isn't working, and so you, the nurse, are going to do the same intervention. So we know that patients with kidney dysfunction are unable to remove water and waste. And if the patients aren't able to remove water very well, then we're going to have to restrict how much water they take in so that they don't get volume overloaded. So most patients who are on dialysis, they're going to have a fluid restriction of 600 mils per day plus a 24-hour loss. So what does that mean? Well, 600 mils is what's known as the insensible loss. In other words, that's the loss of water from the respiratory tract, through the skin, through poop, whatever. It's the insensible loss, the things you can't measure. And then the 24-hour loss means, let's say the patient has peed or urinated a total of 500 mils in the day, and therefore the next day they would take 600 plus 500, and that would give them the 1100 mils that they're allowed to take in that 24-hour period. So they're always a little bit behind. And then what about water fluids are not usually restricted in CKD stage 1 to 4, but diuretics are used. Avoid salt. Notice iron supplements. Why does the patient need iron supplement? Well, remember that these individuals can have persistent anemia because the kidney's not making erythropoietin, and to combat that anemia or help it, they will take iron supplements. Note that iron has to be taken on an empty stomach, but that could cause nausea. So at the very least, patients are encouraged to take their iron either 1 hour before meals or 2 hours after meals. They may be prescribed erythropoietin sub-Q. Now, ACE inhibitors, or ARBs, angiotensin receptor blockers, are a key component in the preservation of kidney function. Why? Because, as was mentioned before, when the kidney nephron is struggling, or is the glomerular filtration rate is declining and the kidney nephron is struggling, the kidneys do RAS. And then what happens with RAS is it hurts the kidney because it causes problems with sodium retention, which increases water, and that puts another burden. So it's kind of like the kidneys do the RAS, but it ultimately will cause the nephron to be harmed even more. So we have to completely cut the RAS system off. And so almost any patient who has a kidney dysfunction problem will be on an ACE inhibitor or ARB, and they've got to take it faithfully. Hyperlipidemia needs to be treated because fat and cholesterol are harmful to the kidney blood vessels. The blood sugar elevations are harmful to the kidney blood vessels. And of course, drugs are harmful because the kidney has to clear certain drugs. And what's on the list of certain drugs? Well, NSAIDs. And then, of course, if, let's say, the patient has known renal dysfunction, they're in stage 3, well, then we probably wouldn't want to give them gentamicin. Perhaps we would want to give them an additional drug that's not as harmful to the kidney. What else should the nurse be looking out for or suggest as part of the SBAR? Well, that's calcium supplements. Calcium supplements should be given on an empty stomach. Calcium can be lost from the bones. We'll talk about that on the next slide. And so patients with kidney dysfunctions are at risk for osteoporosis and pathological fractures. Now, it stands to reason that whenever you're doing a dietary measurement for a patient with a calcium problem, you think of dairy products as things that they should ingest. Well, that's not true in renal dysfunctions, because calcium products such as milk and ice cream and yogurt and cheese have phosphorus in them. And in fact, phosphorus is in a lot of preservatives. And patients who have renal dysfunctions have high phosphorus levels. Again, we'll talk about that in just a second. And then individuals with kidney dysfunctions have to take a phosphate binder because of these high phosphorus levels. Now, phosphate binders have to be taken with meals. What's some names of phosphate binders? Calcium carbonate, calcium acetate. These are what's known as antacids. So they're great drugs because they bind phosphate, but they also provide that bicarbonate that the kidney's not making. Now, we can't, or the patient with renal dysfunction cannot take foods that contain magnesium. In other words, certain antacids contain magnesium, and patients don't want or can't take that. Why? Because potassium and magnesium are twins, and they really are kind of excreted as a duo. So if your patient is holding on to potassium, then they're usually holding on to magnesium. It's a waste, and so therefore patients shouldn't take it because we don't want the duo, potassium and magnesium, to be elevated. So let's do some patho-review about phosphorus and calcium. So the kidneys remove water and waste, and one of those wastes is phosphorus. We usually need to get rid of potassium and phosphorus. We don't hold on to a lot of it. We get a lot of phosphorus in the diet. As I said, it's one of those key ingredients in a lot of processed foods. And phosphorus, for healthy kidneys, they can remove it. But when the kidneys are not working very well, when they're in any of the stages, then the kidney is a higher burden and the kidney cannot get rid of it. So the phosphorus levels will go up. And because phosphorus and calcium are competitors, whenever the phosphorus level goes up, then the calcium levels in the blood will go down. That's how the body works. And whenever increased serum phosphorus occurs and decreased calcium level occurs, then the body needs calcium a lot to do a lot of functions. And so the body will try to equalize that out by increasing the calcium levels. And to do that, it must get calcium that's stored in the bones. So the parathyroid hormone will go up. This will cause the calcium to be lost from the bones. And that's the relation of not only phosphorus and calcium, but it's also the relationship of why, or the reasoning why, those bones become osteoporotic or porous. And so this is what causes patients to have pathological fractures. And there are a lot of patients who are known to have kidney dysfunction, and healthcare providers will actually start looking at the phosphorus levels and the parathyroid hormone levels because it's a very strong indicator of their kidney dysfunction. And so it's kind of used as a marker. That's a physician responsibility or a renal nurse practitioner's responsibility. You just need to be aware that calcium goes down, phosphorus goes up, and phosphorus-containing foods. So again, in addition, the diseased kidney cannot produce the substance, the hormone that activates vitamin D. So in addition to having low calcium levels, it's very difficult for the patient to replace it because calcium is difficult to absorb from the foods without activated vitamin D. So that's the pathological review. You're not likely to be asked about that, but some students don't get it, and I really want to focus or really want to emphasize the fact that phosphorus is a problem in any patient with kidney dysfunction. You need to be aware of it, and you need to watch out for it. So list the key nursing interventions. Again, some more of them. There's a whole lot of them, and I can trust me when I tell you this is what you're going to be tested on. So what else is a problem? Well, we know that the kidney is not getting rid of waste, and one of those wastes happens to be potassium. So there's a listing of all the foods that potassium is in. And what about elevated potassium levels? Well, you guys all know that it's a cardiac issue because elevated potassium places your patient at risk for cardiac dysrhythmias. And so, if an individual has been a very naughty patient and they've been eating a lot of oranges, bananas, and yellow vegetables and have been taking a lot of fluids, and then their kidneys have all of a sudden not worked as well as they have in the past, that serum potassium level can go up, and so perhaps they present to the emergency department because they're short of breath from volume overload. And the healthcare provider measures the blood levels and they see that the potassium is up. They know that their patient is at risk for cardiac dysfunction. So they may give the patient K-exolate. Now, its formal name is sodium polystyrene sulfonate. So you got to know the generic term. So sodium polystyrene sulfonate is the generic for K-exolate. So what does K-exolate do? Well, it removes the excess potassium in the stool. It draws water and potassium from blood into the bowel, and then it causes the patient to have diarrhea. So how do you know that this drug is working? Well, number one, if the serum potassium level goes down, but you know in a quicker method that if the patient has bowel sounds and they're pooping, then way to go, the K-exolate or sodium polystyrene sulfonate should be working or should be able to work. So that's something that your assessment as part of it. Now let's say the individual comes in with shortness of breath. Again, blood levels are measured and the physician's concerned because the potassium level is up. And the EKG will be done and the physician says, whoa, this patient has a cardiac abnormality right now. And so therefore we're really concerned about that elevated potassium level and the cardiac issue. We need to get that potassium level down quickly. How is that accomplished? Because if they gave K-exolate or sodium polystyrene sulfonate, it's going to take some time. The stool doesn't respond in a second. It's going to take a little bit of time. So if we quickly need to lower the potassium, then we're going to give insulin and glucose. Now, insulin and glucose doesn't get rid of potassium. It just simply shoves it or sequesters the potassium into the cell. The cardiac issue is still present, and so physicians will also order calcium chloride or calcium gluconate to ensure that the cardiac cell membrane is stable and that the individual doesn't move into a lethal dysrhythmia. And so that's the process. Insulin and glucose doesn't remove the potassium, it just moves it into the cell, and so we still have to give the K-exolate to get rid of it at a later time. We're just trying to hide it right now, and then we give calcium chloride or calcium gluconate to stabilize the cardiac membrane. Remember that salt substances contain potassium also. Other key nursing interventions is about protein. Now, protein is not restricted in the diet. It's given at the normal amount. But we don't want the patient to eat a steak every day or take protein supplements because we know that the breakdown of protein ultimately ends in blood urea nitrogen, and then blood urea nitrogen has to be removed by the kidney. So you place a higher burden when a patient eats a high protein. So don't restrict it, but don't let them have high protein diets. The only time high protein diets will be prescribed by the healthcare providers is if the patient's on peritoneal dialysis. Proteins are lost during peritoneal dialysis. More on that in a few. Potassium supplements can be given to a patient who's also on peritoneal dialysis because potassium is lost during peritoneal dialysis. So what I would say is potassium level, whether it can be high, whether it can be low, it's got to be measured. The key nursing interventions continued. So what do you teach the patient from a home care standpoint? Well, they've got to weigh themselves daily because that's really the best indicator for a home patient to know whether they're retaining fluid or not. They should also take their blood pressure because, again, we know that sick kidneys just willy-nilly secrete RAS contains renin-angiotensin 2 is a powerful vasoconstrictor. So not only does it cause sodium and water retention because of aldosterone, but angiotensin 2 in and of itself can elevate the blood pressure. So most patients with kidney dysfunction will have elevated blood pressure, and they've got to keep their blood pressure under control or it'll just damage the nephrons even more. It's just a vicious cycle. Shortness of breath and dyspnea can occur with fluid overload. So again, you've got to let them report any sudden edema and shortness of breath because now we're concerned about fluid overload. Fatigue and weakness can occur with different hypercalcemia, but it can also be a problem with the potassium abnormalities, and then confusion and lethargy is from the uremia. I hope this has been helpful. Email me if you have questions.